So welcome everyone back. Sorry about the slight delay. We'll get over all these technical difficulties very soon. Back to Schwan to tell us more about nerve function, action potential, and neuromuscular junction. Over to you, Schwan.
Thank you. So we've talked about action potential and why it's important that you talk about threshold level, and once you've reached threshold, then the action potential propagates down the axon. The reason why that's important is because once the action potential is propagating down the axon, there's nothing to take it back. And remember, some of these axons are extremely long. They reach from the neck all the way down to the fingertips or the muscles of the hand. So there's no take back on it, for want of a better way of saying it. It reaches the synapse and will cross the neuromuscular junction and will activate muscles on the other side. So good control is quite important. So now we've got to the synapse at the very end. If we take, again, this is keep your drawings simple, don't do anything too fancy, and don't spend time doing art, okay? So if we draw the axon down like this, we can see, and then draw simple flare of that, and then I like to draw a kind of ruffled border to represent vesicle binding to the synapse. I then draw my sarcomere, which is forming a neuromuscular junction, a synapse with the muscle. Okay, if this is muscle, this is axon. You've got your action potential coming down here. I also like to draw little microtubules within the axon potential, and I label them as these are microtubules, and I'll come to why that's important. So once the action potential reaches down here, they open up voltage-gated calcium channels. This allows calcium to enter the synapse, the presynaptic cleft, the presynapse, and this binds to vesicles which contain acetylcholine. Acetylcholine comes from the cell body and is migrating all the way down from the cell body. It's produced in the cell body, migrates all the way down in the pre-created vesicles, which come all the way down to the end, to the neuromuscular junction. So they're essentially a storage container for acetylcholine. Once calcium binds to the acetylcholine, to the vesicle is then able to bind to the presynaptic cleft. Once it's bound to the presynaptic cleft, it releases the acetylcholine into the synapse. Here, the acetylcholine crosses the neuromuscular junction and binds to nicotinic acetylcholine receptors. Now, the mistake everyone makes in this is they keep saying that calcium is nicotinic acetylcholine receptors, and someone's got their microphone on. If they could turn it off, please. Thank you. The nicotinic acetylcholine receptors, everyone mistakes them as bringing calcium into the sarcomere. That's not what happens. They actually are sodium channels. Once the acetylcholine binds to this here, the sodium comes in and creates another action in the sarcomere. This action potential then travels across the T-tube into evaginations of the sarcomere to what are called T-tubules. So you've got action potential traveling this way and coming down the T-tubules into the muscle sarcomeres. Okay, we'll come to muscle sarcomeres and how to draw them and the importance of T-tubules and all of this. But remember, calcium synapse, it's not post-synapse. That's a whole different story. It's sodium associated with post-synapse, okay, to create an action potential in the sarcomere. Now, clinical applications of this is quite important. So we use botulinum injections in our everyday clinical practice. Botulinum doesn't prevent calcium coming in here. It doesn't bind here. It actually binds to the vesicle and prevents calcium binding to that vesicle. If calcium can't bind to the vesicle, the vesicle cannot connect to the membrane, cannot release its acetylcholine. So everyone, when you ask this question, they usually ask you a question along the lines of, where does botulinum work? It's pre-synaptic, pre-neuromuscular junction. It binds to the vesicle. It's irreversible binding. So why is that important to say that? Because even though the effect of botulism is temporary, the binding is permanent. The reason why the effect is temporary is there's a limit of how much acetylcholine a cell body can produce in any one time. And it's actually quite dependent on recycling the acetylcholine, which has been released into the synaptic cleft. So what you need to know about this is once acetylcholine binds here on this on the nicotinic receptor, it's cleaved in half by its cholinesterase, which then creates two parts, acetylcholine and choline. These are reabsorbed into the presynaptic and then are traveling back up the microtubules in separate vesicles to be rebound together by ribosomes again in the cell body. And then as you can see, it's a recycling process. It has to be created. So what happens when you use botulism then is that there isn't this recycling of acetylcholine. Acetylcholine is now trapped in this vesicle. So for some reason, the cell seems to think it's been injured and it creates sprouts of axons. And these axons try to find the muscles that it was originally trying to innervate. And for a few months, you get this sprouting of axons. But usually what then happens is instead, the cell body manages to find more acetylcholine over a few years, and builds up enough acetylcholine back in its cell body to be able to start the whole process again. Once the whole process starts again, these sprouting axons disappear. Okay? So does everyone understand that?
I think that's very important principle you said, Shwan, about the botulinum toxin injections and how they inhibit the release of acetylcholine, and it's very commonly repeatedly asked question on these stations and even in the theory exam. But I haven't received any questions, but do you have any questions? Do you want to put the candidates? We have at least three people here going for April exam.
Mm-hmm. Could you tell me in the process? I've described something that's binding with which is pre-neuromuscular junction. Is there any chemicals we use or anything we use which is post neuromuscular junction?
Yes. Can I put this question to Din Oud Farid, please?
Just put my chat on. Hi.
Hi.
Hi, Fraz. Okay, so post-synaptic. Is it the local anesthetic what we put in to stop the sodium channels?
So yeah, you can make that argument, but are you going to stick in local anesthetic into muscle, or do you aim more to cover the axon of the nerve?
Mainly it's in the muscle, isn't it?
No, I would disagree. Generally, when you're doing local anesthetic, you're trying to individually take off axons like digital block, nerve blocks higher up. You're giving local anesthetic to stop that there. I'm thinking more a systemic drug that anesthetists use.
No, I can't remember.
In terms of general anesthetics, succinylcholine.
Yeah, succinylcholine. Yeah, so that's the muscle relaxant.
Muscle relaxant.
They use. Yeah.
So why is it a muscle relaxant?
I don't know the mechanism of action.
The clue is in its name. So acetylcholine, succinylcholine. It's a binder to essentially the nicotinic acetylcholine receptor. It binds to that. It prevents development of action potential post synapse in the muscle, in the sarcomere. So how does that do that? So have you ever noticed this when you get the patient to agitate or to breathe, and then they stop breathing when they're using succinylcholine? Because what's happening is it requires the gate to be opened by acetylcholine, and then the succinylcholine fits into that and blocks it. Okay, so it needs the gate to be opened first, then it blocks it. So once it's blocked, no more action potential can come across, so that there's no more sodium coming across. into the sarcolemma. Therefore, there's no action potential in the sarcolemma traveling down the T tubules. Therefore, there is no calcium release into the sarcomere. Therefore, the bindings of the actin and myosin fibers will not occur, or the actin and myosin proteins will not occur. So therefore, instead of binding tight, release, and then you get the relaxation of the muscle. Okay?
Okay, we have a comment from Fuad. Go ahead, Fuad, please.
Yeah, so coming back to what Sean has said, in clinical practice, where do you need muscle relaxation commonly in our clinical practice?
Should we put this question to
Fareed, because he was asking
can we put this question to Himanta, please? Himanta, please.
I didn't quite get the question, to be honest. Can you repeat that, please?
So, as Sean said, that with succinylcholine, you can have muscle relaxation. So, in clinical scenarios, which are the conditions where you would need muscle relaxation? In fact, it is important to tell the anesthetist that you may require muscle relaxation for doing that particular procedure.
Well, for example, when you're reducing a dislocated hip.
Yes, and I think that's clinically it's important, because like what I've seen commonly, the anesthetists are not happy to give the relaxation. So you have to specify them, and for the same reason, because then they have to take longer time for the patient to come out. So this can be a clinical scenario they can ask, may not be very common, but as you said, if we inform the anesthetist beforehand that I would need muscle relaxation for the same reason, that it will allow me to have an easy relocation of the dislocated hip.
So times when so you can see why this is important in our clinical practice, to understand where this muscle relaxation is important and when to use it, because the anesthetists don't like using it, because that means the patient is completely muscle relaxed, including the breathing, and it takes much longer for they have to maintain the breathing for that patient, and it takes them much longer to recover. So there are times when you need it and times when you don't need it. So as an example, in my case, my trauma work in a hemiarthroplasty patient with a large head, tight muscles, having difficulty reducing, especially if you're using a hemiarthroplasty, which is one size fits all, rather than risk fracturing the femur, I ask the anesthetist sometimes when I'm having difficulty reducing to give muscle relaxant, and that makes a difference to reducing your hip. Same in a total hip replacement. You can even consider, you should consider using it in a difficult reduction of a child, but be aware some anesthetists would not like to use that in a child, okay? So it's quite important to understand the basic science gives you a lot of understanding of your clinical practice, and to use that in your daily practice, okay? So moving on now, guys. Are you all happy with that?
That's great. Thank you, Sean.
Okay, so a couple of things. To draw a muscle, if you're set to draw a muscle, again, the same principle. Just draw 3 circles and connect those 3 circles. Voila, and just do the same thing. Epi, peri, and endo. And again, it's the blood supply is almost the same. You've got intrinsic and extrinsic blood supply. They create a plexus of blood vessels all around the fibrils, and you can the blood supply to muscle is always very good because of that plexus. Okay, but the blood supply to nerves is good but delicate. You need to be aware of the difference between the two. Now, in terms of muscle, you can make a discussion, a lot of things of muscle, but if you're asked to draw a sarcomere, don't start doing that cross-section stuff. They don't want to talk about that. They want to talk about individual muscle cells and myofibroblasts, fibrous. Okay, so first thing to do, again, nothing complicated. You're not artists. Don't complicate your picture. Just draw very quick lines. So what I like to do is I draw one M line in the middle. And if I can get my pen to work, I'll write M. two Z lines, and you notice I'm drawing my Z line straight. I don't do the Z because that just, it makes it more difficult for you to draw your actin filaments and make sure your actin filaments line up with each other, because it doesn't look good if they don't, okay? Just like that. And then your myosin lines. Okay, next thing to do is to say, this is your Z band, this is your M line, this is the Z band. This is your H band. Sorry, let's draw it down here. H and A. What's the difference? A is all of the myosin. H is only the part which is not covered by actin. I is the whole length of your actin. Okay? So you're all happy to draw that very quickly. Just discuss that because you need to show this cross-section pattern, because that is important in how muscles sarcomeres work. Okay, now the next thing to say about all of this, remember we're talking about the conduction of an action potential from the brain all the way down to the muscle cell, and how it fits into the muscle cell and why do we get contraction in the muscle cell. So we talked about the neuromuscular junction, we talked about sodium channels opening on the sarcomere, which are then propagated down T-tubules into the actual sarcomere itself. The T-tubules, for want of a better way of saying it, is where the actin and the myosin filaments meet up. The T-tubules interspace into those. The sarcomere, the membrane around the muscle, invaginates into the actual sarcomere itself, creating these T-tubules to allow sodium channel. Within the T-tubules, sorry, not within, as the action potential comes down these T-tubules, they create voltage-gated channels which open. These voltage-gated channels, they bind to, these voltage-gated channels are bound to sarcoplasmic reticulum mechanically channels. These channels allow calcium from the sarcoplasmic reticulum, which is intracytoplasmic, like a vacuole, for want of a better way of saying it, or a small sac inside the sarcomere. They contain lots of calcium. Once this voltage gate comes here, it opens up these calcium channels, and the calcium channel floods into the sarcomere. The more calcium that gets into the sarcomere, the more the muscle contracts. And I'll show you why in a moment. But I just want to rehash what I said from the beginning, all the way down, so you guys got this into your head. I can't emphasize this enough to understand what electrons are involved in each part. So, what ions are involved in each part. At the in the axon, it's sodium and potassium. In the pre-synapse, calcium binding to vesicle releasing acetylcholine into the synapse, acetylcholine crossing the synapse, binding to the postsynaptic in the postsynaptic cleft, which then opens up sodium channels. These sodium channels create another action potential in the sarcomere, which travels down the T-tubule like an action potential of an axon, which opens up. The best way to describe it, it's like you've got axon, pre-synapse, post-synapse axon, and pre-synapse again, because you're then opening up the sarcoplasmic reticulum and calcium floods into the muscles. So you get it? Sodium, potassium, calcium, acetylcholine, sodium, calcium. Yep. Okay. So now the next thing to say is the difference between actin and myosin and why they work. So actin is bound to the Z discs. The Z discs is two Z discs is one sarcomere. So between two Z discs, you've got one sarcomere. So this is important to show. I'm going to draw it in a very microscopic way so we can see as much of it as possible. So if I draw the actin, what we then have is actin, which I'm going to draw a little bit more complicated than that. You also have tropomyosin cleaving around the actin. Okay? In the tropomyosin, you have troponin compound, which we will draw in green, which actually which are bound to the tropomyosin. The reason why that's important to understand, actin cells itself have a myosin binding site within the actin fiber, within the actin proteins. However, this myosin binding site is covered by tropomyosin, not myosin, but by tropomyosin. The tropomyosin prevents myosin, the thick band myosin that we were talking about here, from binding to this actin binding site, to the myosin binding site on the actin. Once calcium comes in here, the calcium reacts with binds to the troponin C, which changes the configuration of troponin I, which allows troponin T to pull the tropomyosin away, and it causes a mismatch between the tropomyosin and the myosin binding site. That means now you have an exposed myosin binding site, which allows your myosin head to bind to the myosin binding site. Remember, your myosin is made out of 2 heavy chains and 4 light chains. In the body, we don't know what the 4 light chains, in the human, we're not sure what the function of the light chains are, but we do know that the heavy chains, S1 and S2, are involved in binding of myosin heads onto a myosin binding site on actin. So what then happens is, once that's exposed, that means that's a magnet for the myosin head. The myosin head binds to the actin. If everyone can see my picture, I'll just show you. Myosin head, this is myosin head. My finger is a myosin head. That's myosin protein. That's actin up here. Myosin head binds to the myosin binding site. And then as part of the ATP cleavage from ATP to ADP, you get reconfiguration of the myosin head. And as the ADP is released, you have the myosin head coming off. Once another ATP binds to the myosin head, it charges the myosin head, so it allows it to reattach. But it's this movement that's important, because as you can see, this movement is pulling the actin in. So if you imagine this is actin filaments, this is myosin filaments, and the heads on the 2 filaments are working against each other, you're getting the Z discs coming closer together. Does that make sense?
Yes.
Okay.
Right. Thank you.
So the more calcium you have, the more myosin binding sites are exposed, and therefore the more active the myosin heads become. Remember, this is an energy requiring process, so ATP is part of this process. If you take a look at Ramachandran, it just draws you a lovely diagram. It tells you straight away how ATP is involved in all this. Very easy picture to see. Okay.
Okay, I think common questions that could be asked on this topic include types of muscle fibers, slow twitch, fast twitch, and what type of energy each one use. It's very important to read about that. And also, they could ask about different types or shapes of muscles, and obviously the sarcomere function that Shwan explained here. They could ask you also about how different types of muscle actions and isometric, isotonic, isokinetic muscle actions, and this could all come into the same station. All depends on how smoothly you are flowing through the topic.
To be honest, the discussion of how to draw a sarcomere and how it functions and its connection to action potential will take you past 5 minutes. If they say, draw me a cross-section of muscle, that's potentially talking about all the other stuff. What is concentric, what is eccentric activities, and so on. Okay?
Excellent.
Someone was asking me, there was a question, sorry, on the chat. How is resting potential established and maintained? I presume you're talking about within the axon, Mohammed? If Mohammed could confirm that's what he's talking about within the axon. No. Okay. I'll just presume.
Yeah.
I'll just presume that's what he's talking about.
Yes, within the axon.
Okay. So, Mohammed, remember we were talking about voltage-gated channels. There's 3 types of channels in the axon. First is voltage-gated sodium channel, then voltage-gated potassium channel. These 2 channels disrupt the resting potential, okay? But what maintains the resting potential is ATP, sodium potassium exchange pump. This is an energy dependent pump. So the body has to work to continuously maintain resting potential. It uses energy to maintain resting potential. If you ask any nutritionist, they'll tell you your minimum, if you're completely resting, you'll need 1,800 calories to 2,500 calories, depending on your body weight and size. That's because your body needs energy to maintain the basic functions, such as maintaining resting potential in your cells, as well as getting muscles to breathe and heart to beat and so on.
Great. We have a couple of minutes, Juan, to analyze this topic, please.
Okay, so can I just go back to polio, if you don't mind, just for the sake of completion? There is post-polio. I knew this really well, and I don't know why I forgot it. But essentially, just want to make sure you guys understand. So polio affects the motor neurons. It knocks them out as a child. It's a virus that lives, I believe, in the anterior horn cells. The posterior horn cells, and wipes out axons. What happens is it selectively destroys motor nerves.
No sensory loss.
Okay, so a patient who has normal sensation but motor loss, be wary, that's a polio patient, not cerebral palsy, not anything else. It's a polio patient, okay? The second thing to say about that is if they survive their first attack of polio, and some patients survive and don't have any serious symptoms of polio, but then later on in their middle age, they develop what's called Post-Polio Syndrome. The explanation behind this
Can I
is-
just, sorry, Shwan, I think you were right first time. It is viral destruction of the anterior horn cells in the spinal cord.
Yeah, apologize.
Yeah.
That's correct.
Yeah, anterior horn cells, yeah? And also it can affect the brain itself in addition, the brain stem also, so yeah.
Okay. So these, so a child that survives polio without symptoms can still develop post-polio syndrome, because what's happening is that the nerve cells, remember I told you when you get botulinum injections, what happens is the axon seems to think it's injured and then tries to sprout extra synapses to create, to try and recruit more muscle fibers. So the best way to talk about this is every nerve, one nerve will supply multiple motor fibers, but those motor fibers don't lie next to each other. They're actually very separated. And so, for example, let's talk about nerve 1 supplying this fiber here and this fiber here. That's nerve 1, skipping the one in the middle. The reason why this occurs is it's so that any nerve that's stimulated will cause contraction across the whole muscle body as opposed to one small part of the muscle body. Now, the bigger muscles in the body have far more muscle fibers per nerve than smaller fine-tuned muscles like the ones in the hand. So we have more nerve endings. We have more nerve endings in terms of how many muscle fibers than in the hand than we do in our quadriceps. As a child, when the nerves are damaged or destroyed, the other surviving nerves try to recruit the muscle fibers that have become denervated. So a larger portion of the muscles are now taken up by less number of motor nerves. And this is fine. So the child has a normal childhood, potentially normal childhood if they're not severely affected by their polio, do not have long-term consequences initially, seem to recover from their polio, but when they reach middle age, what happens is that there is a fatigue of those nerves. They finally die out. They can't take anymore, and you get massive muscle denervation at that point, because these nerves, the one theory is that these nerves overwork this situation, and therefore they're tired. There are other theories. For example, there's a connection with possible reactivation of latent viruses. That's one theory. And another possibility is that they get hit by another virus, an enterovirus, which they are more sensitive to because they've had polio and so on. Do you understand that connection? It's really worthwhile getting that in, because if you get a polio patient, it's nice to be able to talk about the pathophysiology associated with post-polio syndrome.
Thank you, Sean. I'll be posting these recordings later on for people to listen to again and see again, so they can thinking those information more. Any comments about these topics, Ramesh, on neuromuscular junction and the muscle cell function?
I think somebody put it as in the chat. Somebody has put it as dominant effect.
Yeah.
So the idea is, because there is concentration difference of the sodium extra and intracellular, there is a drive for sodium to come in, and it continues until it reaches what is called as Donan equilibrium. Okay, so it's not just the Donan effect. It's the idea is to maintain equilibrium, which is called Donan equilibrium.
Okay.
And that basically, I think, what he was trying to say in the chat, Mohammed.
Yeah, thank you. Thank you, Ramesh, thank you for the clarification. That's great. I think we are running out of time now. We've had the hot seat question, but I think we're running out of time at this moment.
Happy to do hot seat with anybody for